So if you look on page 2, so teratogens can be anything. They can be, we think drugs, but they can be chemicals, they can be environmental, they can be physical, mechanical. Lots of things can cause a change in the development of an embryo. Most things happen in the embryonic that we refer to as congenital malformations. So like cleft lip that you see would be a common, more common and visible one. Things that happen in the very first 2 weeks, I put in your handouts, usually all or none. Either it destroys the embryo, the zygote, and there's nothing. It just destroys. Woman may not even know she's pregnant. The second would be that it recovers. It's a sublethal blow. It's a very regenerative, oh gosh. It is a cell that regenerates easily. I mean, if you think about twins or multiples, that cell can divide and redo. So, so in germinal, it is likely that it will just end the pregnancy. The embryonic is the real problem area because that's where organogenesis takes place. You all are born into a time where you can know you're pregnant within a few days after you think you've ovulated, before you even have a period. So in the past, before 25, 30 years ago, most of the pregnancy tests were not good until you had missed a period. Now they're much more sensitive. Now you can know 5 to 7 days, which is about implantation time and when the hormones start to be secreted, and so those tests are now so sensitive they can pick them up before you miss a period. So in the past, women might get 2 months, especially 2 months down the road, 8 weeks into a pregnancy before they realized they were pregnant. Women who didn't ovulate regularly and didn't have regular cycles, they might get used to going 2 or 3 months without a cycle, and so they may not check, or 4 months. So things are very different now than they were before. So now we can very easily, more easily, prevent those effects, at least from a drug standpoint, on the embryo. The things that happen in later, in the fetal period, tend to be more, they can be functional or structural. The brain is one of the last to fully mature, so it can suffer damages very late in pregnancy. But most of those are not drug related. Okay, so on that second page, you've got the embryonic period, the first 14 days, sorry, pre-embryonic, first 14 days, embryonic, the first 8 weeks. Know that time frame. That's an important time frame. And then fetal period from 9 weeks on. Next page, you know I like pictures, so I pulled several different ones for you to look at. This one gives you the different things that can, or the different organs and when they are developing. So if you think about cleft palate, you can see it's at the 6.5 to 16 weeks. Remember we talked about thalidomide, and what did it affect? Limbs. Okay, so you can see the limbs, upper and lower limbs are 4.5 to 9 weeks gestation. Others would be like tetralogy of flow, heart, eyes, I can't think of any. CNS, what do you think there?
Neural tube defects.
Neural tube, so anencephaly, spina bifida, those kinds of effects. The next chart I really like because it just kind of puts it all together. So it's there, they're just there for you to look at in different ways. Okay, bottom of page 4 is where I'm picking up again. So the problem with drugs is that we usually don't do drug studies in pregnant women. So a lot of things are anecdotal. A lot of things also come from animals. So we look at, does it affect animals? If we get a lot of teratogenic effects from animals and we get case reports in women, then there is a stronger evidence, or more, maybe not so much evidence, but more of a labeling that would indicate potential harm. Some drugs we know without a doubt will cause congenital anomalies, and we're going to go through those. So a lot of what we know is based on animal studies, and then there are some drugs that keep registries. So if you're a woman who's put on that drug, or you develop a congenital anomaly, they may put you on a registry and they will follow you out. Okay? The retinoids come to mind in that regard for acne. Almost all the drugs will cross the placenta. So whatever you do to the mom, you do to the baby. Okay? Sometimes the baby can handle it fine, there's no effects, but keep that in mind. Also, most drugs will go into breast milk, and we'll talk about that tomorrow, and how we, what to avoid, or how to, if a mom has to use it and wants to breastfeed, the alternate. Page 5. There are two systems for grading risk in pregnancy. There's an old system, and all the drugs that were approved before 2015 have that old system designation. A new system went into place 2015, and I will show that to you. The old system is very much based off of the animal data and what we know in pregnant women. So if you look at it, it goes A, B, C, D, and X. So A, it goes from best scenario, X most dangerous, and we've talked about these, some of these before. Or you'll see me list them in the handout. Maybe not draw your attention to it, but it may be there. So A would be the best, the safest of the drugs. We've got controlled trials in women for whatever reason that have shown no increased risk. B is no evidence of fetal risk. So we've got animal studies that either say there's no harm to the fetus, or we have studies in women that say there's no harm to the fetus even if they showed up an animal. C is less evidence available. So that's what gets that. So animals have shown an adverse effect, or there's no well-controlled studies. Or there's no animal data and no information in women. Okay? So A, you can, if you've got a drug that's labeled a pregnancy category A, then you have no problems in prescribing. B, there would be a little bit of concern, but the benefits probably way outweigh any risk. C is where you are at that tipping point of if you have other drugs that you can use them. If you don't have any other drugs to use, then your risk is probably acceptable. D, risk is unacceptable. Here's where you've got higher risk, but in some cases, the risk may be acceptable, but less so. D's you should pay attention to, and in that table at the bottom, I pointed some of those out. So D has risk identified, and here's the real heavy weight of benefit versus risk. X, never used. So the table, so these are suspected or proven. If you look at the X's, we've talked about those. Methotrexate. Systemic retinoids we have not. Those are what we will talk about when we get into acne. Any of these, well, at least with the retinoids, because you're usually dealing with adolescent and young women, you have to have pregnancy tests every month. They will not, the pharmacy can't dispense the drug until it's been signed off. There's a program that is in place. So there are lots of hoops to jump through in order to get that drug. Warfarin, we talked about it. So those three, and you, can you tell the highlighted ones you must know? I will ask you. Please do not let those words just fall. I expect 100% right on those. If I tell you it's going to be on the test, I will ask you about a teratogenic drug.
I have a question. Sorry, it's probably a stupid question, but how long do they have to be off the drug before they can get pregnant, or do they just need to stop taking it?
It will depend on the drug. Most of these, once they stop, they can start. But remember, we've talked about drugs. We talked about leflunomide in with rheumatoid arthritis, waiting months. So some of these will require a long period of time. Most of them have a short recovery. Some of them will affect male as well, and I'll show you. And so you see in this system, there's nothing that addresses male fertility or male risk inferred to a fetus or an embryo, but the new system does. Okay. The D's I'm also having you learn because they're so common, or they are so teratogenic, and if you come across them, you need to remember. So ACE inhibitors and ARBs, we don't use them in pregnancy. We just got through talking about methimazole for thyroid, for hyperthyroid. Remember, we never use it in the first trimester. We always use what drug? PTU, and then we can switch back. So a lot of these drugs you'll see first trimester only. Some are throughout pregnancy. Carbamazepine. Remember we talked about carbamazepine and valproic acid. What do they do? What do we make them take a lot of big dose of in order to prevent? Folic acid, these are neural tube defects. Okay, paroxetine, phenytoin's another one. Tetracycline, what's the problem there?
Teeth.
Gray, so it lays down a color in the cartilage, discolored cartilage. It really doesn't weaken and everything, but it's very cosmetically disfiguring. Okay. So know those that are in yellow, know, and I'm going to have you learn the old designation for them. Okay, so a new system, well, let me show you some. So here's phenytoin, and it even has a syndrome. So alcohol has a syndrome, so fetal hydantoin syndrome. So you see the cleft lip and palate. Microcephaly is a hallmark of phenytoin, and mental retardation or lower IQ. Here's valproate, so here's a neural tube defect, so this would be spina bifida. So here's tetracycline, so the teeth, you can see the discoloration. Here's Accutane. This is a drug used for acne. You can see the malformation of the head and the palate, heart defects, lots of side effects with the retinoids, or anomalies with the retinoids. Here's thalidomide. I showed you this picture in the very first module with the phocomelic limbs. Okay, so let's look at, this is the current labeling, this is the new labeling, it's already in place. So what it's referring to, and I'm going to show you, I'm going to take you into prescribing information. I often refer to it, but there is prescribing information on every drug available. It is pretty much a summary of all the information that the FDA required in language that a prescriber could use. Anytime you go to the website of a drug, at the top usually it'll say prescribing information. If you click on it, it'll often ask you, are you a provider or a patient? I don't know how they think they're policing that, but you can go into that. I go back to it quite a bit. I'll often go back and go, okay, what are you exactly indicated for? What are your, it'll give you the black box, it'll give you a dosing, gives you side effects, and it puts it all in a summary form, and then there's the long form that follows it. They are all laid out the same. So this numbering organization is the same for every drug, okay? So what they did under 8, which is where the pregnancy and breastfeeding is, or women's effects on women's health is all in that section. So what they did is they increased the amount of information that had to go in there. So you could go in there as a provider and get a lot more information. Because if you just have this, all you really had to remember was A's good, B and C, okay, stay away from D, stay away from X. You really didn't know a whole lot more except that women's studies or animal studies. So the pregnancy tells you the use of the drug in the pregnant woman. So look at this at the bottom of page 5. I'm going to walk through that. It will tell you if there's a registry. Those are helpful. And you may be required. If you're required to enroll a woman, there will be a whole lot of other structure around that will organize you to do that. It wouldn't be, you just have to know that. And usually most of those drugs will have to go through specialty pharmacies, so they'll have all kinds of regulations. Or the pharmacy will have to be licensed to dispense that drug. And so they'll require paperwork. They'll go, I can't give this into your patient until you send me this, send me labs, send me whatever authorization form is required. Every drug will have a different format, or form, or process. Okay. Maintains on how pregnant women are affected when they use the drug or the product. This will be important. You will run across this all the time. There's all kinds of sources out there. These are easy to get. You can get them from your phone, website. I'll show you one on Coumadin. Lactation. Can I use it when I'm breastfeeding? Impact on reproductive, now this one's new, impact on reproductive potential for males and females. So as of 2015, now we have this data on drugs that have been approved since that time. Now, manufacturers can put that in there, but they weren't obligated to do it if the drug has been around before that time. So it'll tell you, do you need to test pregnancy before you give it, what kind of contraception would be required, and infertility rates. Okay, so a lot of good information, easily accessible. Okay, so this is one, I'm going to show you the package insert. There's an easier way to do this. I would love to know. Okay, this is what they look like. So this is what you can get in at the very top, at the beginning of every drug that is out there. So it will tell you, and it's the highlights is what they call it. So if there's a black box warning, it will be right off the bat at the top. And then they'll tell you changes, which is nice to know if you're looking for history. Indication and use. These are FDA indications, because that's all they're allowed to put in there. Limitations of use, dose and administration, the forms, dosage forms, so if you want to know, this is a good place to go. Contraindications. It also gives you warning, precautions, adverse effects, it'll be the big ones. Drug interactions, use in specific populations. Okay? And then, for this one, we're going to look at number 8, section 8. Now, Coumadin's been around a long time, but they've gone ahead and, so they do the risk summary for you, and then they're going to give you effects on baby, effects on lactation, male and female reproductive use. I'm telling you, it's a good place to know where to go to look, because it will come up. Questions about those? Okay, so that's what I have to say about teratogenesis. Any comments or questions? Yeah, Jen.
Do you want us to know just what class or what risk categories they're in, or do you want us to know risk category plus the defects that they cause?
No, well, go back to whatever I said in the objectives, but I do want you to know those with risk categories. More I'm showing you the pictures to impress on you the what you can end up doing. Okay. The good thing about this topic is that most of the drugs you've heard of before. So now it's learning what do you do to treat common problems in pregnancy. So have y'all talked about supplements? So you okay, it's just the eyes. It's like, yeah, we've heard this till we're blue in the face. Okay, do you feel like you know iron well enough? Would you skip? Really? Okay, I'll go over it for those that are shaking their head. Okay, so iron. So why do women need iron when they're pregnant? Say it again.
Fetal blood supply.
Fetal blood supply. Okay, is that a big part of it?
The blood volume expands.
Female volume goes up how much? Red blood cells go up what? 50%. It's huge. Okay, so you got fetal blood supply, you got the placental unit, and you got the baby. So big increase. So lots of iron. Okay, so who's at most risk? So if you're starting out anemic prior to pregnancy, who else is at risk? Closely spaced, no recovery time. Who else?
People who don't get iron in their diet.
Okay, those who may be not anemic but don't have a large intake in diet. Okay, dietary intake. What else? Multiples. Okay, those are common ones. Okay. So the recommended supplement is 15 to 30 milligrams a day. So be sure you know that. That's easily, by most prenatal vitamins, are going to take care of that. Women who are at risk are going to need more and may need other supplements. So what's the downside of taking iron? Constipation. And so the good and the bad is that usually that iron is going to be needed early on. That red blood cell supply goes up fairly early in pregnancy, and constipation tends to come fairly more late in pregnancy because of the rising progesterone levels. Okay, so what did we talk about in the heme? Not elected, you didn't elect that. the heme force. What did we talk about in terms of different ways we could help women tolerate it better?
Every other day.
So every other day, liquid, you can start with the liquid and go low dose and increase it. The only problem is that all prenatal vitamins will have that in there. So if you're going to have to go above and beyond that, then you might look at these other ways to supplement them. Okay, so intermittent. So what form does iron have to be in order to be absorbed? Ferrous. Okay. So if you take ferric, what do you have to have in place to convert it? What environment?
Stomach
Acid. Okay. So what can we usually have people take with their ferrous sulfate in order to increase absorption?
Orange juice.
Orange juice, vitamin C. I can tell you a lot of women are not going to want orange juice. So you might think about the tablets. It makes them sick. It makes you sick to your stomach. Or it might. So think about that. In a lot of those prenatal vitamins will include some vitamin C along with the other ingredients. And I'm going to show those to you in just a little bit. So ferrous sulfate is, so when we're talking about iron, we're talking about it in elemental form, right? So what's the elemental form mean? It's the actual mineral, it's not the salt form. So ferrous sulfate, most common is what percent? Elemental iron. 20%. You must know that. It's too common. Okay? Under women at risk, so 60 to 120, be sure you know that. Look at those other risk factors that we may not have mentioned. Would be chronic aspirin or NSAID use, those that are big donors in terms of blood. Okay, questions about iron? Okay, folic acid, so that is the neural tube. You all got that down. Oh, let me show you. This is, so there's over-the-counter prenatal vitamins and there are prescription prenatal vitamins. They will differ in their amounts of those supplements. So what do you see here? What do you see in terms of the folic acid? What about that dose? What do you... Who would this fit, or who would this be best for? People who are trying. Okay, so any woman could take this. Is it sufficient for a woman who is trying to conceive? Why not? What's the range? 8. So it's 400 to 800 is for like your age group. Okay. What else up there? The calcium. What's the calcium requirements in, since you all been gone over supplements, what's the calcium requirement? 1,000, and, but for who?
Under 50. Non-pregnant under 50.
But who, what is it for pregnancy? And what determines dose? Age? Okay. So 1,000, 1,200, what is it? 1,500? Okay, we'll come back to that. Where's the other one? Iron. So is that enough iron?
No. Well, yeah, technically.
Well, what do you remember about iron? How does the body regulate it? Highly regulated, isn't it? Will it absorb all the iron you presented? No. So it can upregulate or downregulate. So 17 may be fine for someone who is not anemic, great red blood cell mass, great hemoglobin, hematocrit, because they can uptick the amount of iron they absorb. You might take this time to just pull that lecture out from Pharm and look at that regulation of iron. Just remind yourself about it. Okay, so this is an over-the-counter. Let's look at the, I don't know how well you can see this. There are prescription prenatal vitamins. The one that I'm showing you is Prenate. Then there's all kinds of others. Natel 1, Gestacare, Prevera, Prenexa, Natachu is them. Okay, so what do you see up there? Difference.
A lot of iron.
So let's start with the iron. How much iron's in there? 28. Okay. So would that be an acceptable one for a lot of women? Yes. Okay. What about the, what do you see in terms of calcium? That's elemental. So it's a lower amount. So there you would have to look at what the woman is taking in terms of dietary. What about, I can't spot it.
Fourth one.
Fourth one, okay. So what about it? 1 milligram. Okay, so that's for most pregnant women. Would that suffice for someone who had a history of neural tube defect in the past or on a drug? No, it will not. Okay, that's what makes that a prescription, is that strength of the, or the amount of folate in it. Why is there, so why is the vitamin C in there? Oh, the iron. Why is there iodine in there? Thyroid. Especially if you're one of those kosher salt, Himalayan salt, sea salt users. Okay. All right, so be aware. So you would have to write a prescription. These will be much more expensive. Okay, so there's the neural tube. So we talked about this probably in neurology. So you see those three dermal layers, or dermal layers, sorry, ectoderm, mesoderm, endoderm, the invagination of that tissue, and then the formation of that neurotube closes off. Okay? So what happens is you're affecting it that early, and where you affect that neurotube is what kind of defect you'll get. So the higher up, you'll get more brain or anencephaly. Lower down, you'll get the spina bifida. Okay. All right, so under folic acid, again, 400 micrograms a day is what's recommended for all women of childbearing years, so all of you should be doing that, or your wives, or your girlfriends, or the women that you know in your lives. And then for during conception, that 400 to 800 micrograms. 1 month before, up to 3 months after conception. So the reason they're doing that is they're just broadening the time so that you catch everything, because not everything is always known. If women have very irregular periods, that last menstrual period does not always help you. Now, you live in an age of technology, so you can go in and actually look at the embryo and tell how old it is. But that wasn't always in the past. Okay, normal pregnancy, 400 micrograms. High-risk women, be sure you know this one. Who's high risk? So you can identify. They've had a neural tube defect pregnancy in the past. If they're on carbamazepine or valproic acid, 4 milligrams beginning at least 1 month before conception through 3 months. Here you will have to use a supplement in addition to the vitamins. You cannot supplement them with the vitamin alone. Why would that be? Toxicity due to the others, like vitamin A would be one of them. All right, any questions about the folic acid? Okay, so that fetal skeleton takes a lot of calcium, 30 grams. It's a lot. So the RDA for during pregnancy for women who are 19 and over, so that's where the age comes from. So your adolescents, why would they need more calcium? They are also in a bone building phase. I don't know why the 19 was picked. I don't know the history of that. So 1,000 milligrams for women over at 19 and over, and under is 1,300 milligrams. So if you go back now, to that prenatal vitamin, will that help? Will that cover it?
No.
No, it will not. Because you've got 200, 300 milligrams of calcium. So you will have to assess their dietary intake and use that route if you can, and if you can't do that, or if they won't, or they have some type of intolerance, then go to supplements. Okay. Remember those elemental, again, calcium is elemental just like iron is. Calcium carbonate is what percent? 40%. And why would I ask you to know about calcium citrate? 21%. When can you use it versus calcium carbonate? PPIs. Okay, so acid. So whether they're taking acid suppressant. Some women may, if they've got GERD, that usually tends to be later, in the later part of pregnancy. So keep that in mind. All right. So that's the supplements. You should know, well, if you miss any of it, I am just going to be mad at you. Okay, have you talked about morning sickness?
Nope.
Oh, good. I love fresh ears. Okay. All right. So what is morning sickness? Acute, not awful. Okay. So it's usually due to that changing hormone levels that are rising during early pregnancy. It's a change similar to when women start combination of oral contraceptives, change in estrogen and progestin amounts. So most women will have some degree of morning sickness. In fact, it's thought that the more stable the pregnancy, usually not the sicker people are, but that's usually a good sign. So most women are going to have some degree. Most of the time it is mild. Most of the time it will go away by the end of the first trimester, which would be how many weeks?
12.
How long are trimesters? Okay,
12
13 weeks. So usually by the end of the 12th or 13th week, most women they'll resolve. Usually that second trimester of pregnancy is a very good sense of well-being. Women feel good, baby isn't that big yet, so that usually is a good trimester. And then the third trimester brings its own travails of a big belly. Okay, so there's no adverse effect for mild to moderate morning sickness on a pregnancy. So reassurance. Most women are going to hear it from their girlfriends or moms. People love to tell you all their bad stories when you're pregnant. Is it not true? Yes. They will tell you every terrible thing that happened. And the closer you get to labor, the worse things they tell you. Did they not that? Did they tell you that?
Okay, I did it.
Shannon, you had it 4 times. How? Oh, you're a trooper.
Every time.
Awful. So the stories people told you, or the
Both.
both? Persistent severe vomiting during pregnancy, hyperemesis gravidarum. Who is the famous person?
Kate Middleton.
Yes, my goodness, every pregnancy she's had it. How do we know these things?
Because friends of family, or her friends, or the doctors, or the nurse that treated her tell the tabloids.
Okay, but how do you know these things?
Oh,
On the internet, I don't know. On TV, they put it on the news.
That's the deal.
Okay, so this one's bad. So this one, like her, you usually have to hospitalize because it puts the pregnancy in danger. They get dehydrated, their electrolytes get all out of whack. You'll note down there thyroid. Think thyroid disorders when you see that and test them for it to rule it out. So mild nausea and vomiting of pregnancy. So the goals, symptoms, so we want to make them comfortable. Prevent or correct the complications of the nausea and vomiting, like getting enough Usually you don't have to worry about early in pregnancy getting enough nutrients to the baby. It's more the dehydration and the electrolyte disturbances that are the bigger problems. So with mild can usually be managed with just the foods, the avoidance of smells, avoidance of foods, crackers in the morning, something on the stomach before women get out of bed. Those of you who've been pregnant, you want to share anything you did? Kate's smiling. What'd you do?
Crisp celery, really?
Crisp celery? You are too healthy. Ginger ale. Ginger ale. So ginger is a really good settler of the stomach, and so we'll talk about that in others. Anybody else?
I took medicine.
You took medicine. Okay. So let's talk about the medicine. So moderate symptoms. So the medicines can be over the counter, so women may choose to use these without, and a lot of times they're going to have this before they ever see the OB. So the OB usually doesn't start seeing them until they're at the end of the first trimester, about 12 to 13 weeks. So vitamin B6, so pyridoxine, 10 to 25 milligrams every 8 hours, 6 to 8 hours is safe. Can be used in combination with doxylamine as well. So it's usually recommended to start out with pyridoxine. If that doesn't work, then add the doxylamine. So you'll see the risk of reducing nausea and vomiting is by about 47%. There is a combination product that is a delayed release. So it has 10 of pyridoxine, 10 of doxylamine, a little bit lower dose. So there, you can take 2 tablets at bedtime if the morning is the problem, can take them throughout the day. Again, mark under there, scheduled dosing is better than PRN. And that you can assure them that this is very safe. I could not stand the smell of red meat. It made me sick. I just wanted to vomit. And I craved Korean food. I do not eat it now, but I could not get enough of it. It's so weird. And turkey. I can't eat turkey anymore. I got sick on it when I was pregnant, and I just can't abide it. So, okay. So Shannon, what were where did you have certain foods or smells?
Oh, I had hyperemesis.
Oh, you did. So can you share with us your experience?
Yeah, so they put me on an IV in my home.
So every pregnancy you had it?
No, just my last one was my
Really?
daughter. But I had really bad morning sickness with the other ones, so I had to take Zofran from the beginning. And then they gave me some stuff that you rub on your wrist. I don't know what
Oh,
it was.
yes. Yeah. So they set you up with home health care in the home and ran IVs. How long?
I want to say it was at least a month.
So the nurse come in every day and hang it, or?
No, I had to change out my own.
Wow.
Yeah, they taught me and my husband how to do that, and then the home nurse would come every week and check the IV line.
Wow. Okay. So did the IVs make you feel better?
No. I couldn't eat hardly, I mean, I would throw up water with her, and then I would eat like half a sandwich a day.
Wow. Wow. So did it ever abate?
Yeah, eventually, by the time I got to like the third trimester.
Yeah. So that always goes longer. That's a real common, what she's telling you is pretty common. Okay. Wow. Did it affect your pregnancy weight?
Yeah, oh yeah, I was really skinny.
Was she small for gestational age?
No, actually, she wasn't. She was fine.
See, I'm telling you,
She
they
was born early.
came early. Okay. Jessica?
The only thing that I got, with my first daughter, with my daughter, I wasn't sick hardly at all, until I ate, tomato basil soup, so I can't eat that anymore.
Isn't that weird? It
Like,
just
just
sticks
the
with
smell
you.
of it just makes me sick still. I crave salsa, with her. I like ate a ton of it. And my son, I got really sick and they gave me the Vectijus, and that was like a miracle drug. It was like the best thing ever.
So how did you take it?
Well, I started out scheduled like 1 or 2 in the morning, 2 at night, And then, when I started feeling better or a little bit further, I just took it in the morning, but it was kind of scheduled.
So remember these stories to help you remember the information. That's what I think they're good for. Who have I missed? Thatcha, you have any stories?
I had hyperemesis gravidarum.
You did too? Wow.
Mine was extremely sick.
Did they put you in the hospital?
I was in IV almost 4.5 months at home, and then I was transferred to the hospital. I was
Wow.
hospitalized the whole time.
Wow, the whole time? Oh,
Whole time.
How
I was on
miserable.
Zofran, not scheduled as PRN. I just popped Zofran all
all the time.
as much as I needed.
Wow.
I became like stick thin, skeleton. I would say it was so anorexic. I mean, I didn't need. I was
Wow.
not able to tolerate anything.
Was that both of your pregnancies?
Both.
Both. Okay, let me go to April, then I'll come back to you. April, any pregnancy stories?
I had perfect pregnancy.
Of course she did.
Super easy, and the only thing was Kyle, with crew, Kyle was mobilized, so I went to visit him one weekend, and we went out to eat like steak, you know, like big meal, like just, and got back to where he was staying, and the nausea hit, and so I just barfed the whole weekend. But which was great because I got to see him 2 days, you know, every 3 months. So, but he was like holding my hair and everything, and he was like, "What did you eat that was green?" And I was like, "I have no idea. Maybe it just turned green in there." But
Is this like family history? Like, is this like genetic? Like, if your mom or grandma or anybody have like a history of it? Is it going to happen to you?
I don't know that.
My mom never, she didn't even have a morning sickness. She didn't know she was pregnant until 4th month, I guess.
Yeah, see, that's a good history, is that a lot of women went 3 or 4 months. Yeah. Not that I know of. Why, is your mom had that?
I mean, I've heard stories about it, honestly. But my sister had some, all 3.
My sisters and I were nothing alike in our pregnancy, so in of one family. Jenna?
Yeah, I'm just saying, all the women in my mom's side who just like died from puking, like infections and childbirth.
Yeah, did you have a?
Well, I don't know if this counts, but my family told me that during pregnancy we cramp a lot, like we get Charlie horses or like things like that will cramp, and apparently that goes down a lot. That's what she was telling me.
Interesting.
I had a lot of leg cramps with my daughter.
Anybody else? Want to throw their stories?
what about yours?
I was nauseated, but I didn't have it that bad, but smells would really get me. The red meat was just overwhelming. I couldn't even stand to look at it. It made me, raw hamburger, I just couldn't look at it. That was about it. I really didn't have it that bad. Okay, ginger. So, who mentioned ginger? Shannon? So ginger is a really good, like ginger ale, like, you know, from Buffalo Rock. We have our own special in the South. Anybody down that phrase, Buffalo Rock ginger ale? It is the best. It has a great bite. In fact, Dr. Britton and I love it so much, you can't buy it past the Alabama border. So when we go to Alabama, we load up. We bring back probably 40 cases. And this will only take cash, so we go to the Buffalo Rock distributor, we give them $300, and they give us 40 cases of Buffalo. We love it, it's great. But I find most people don't. It's a very strong ginger taste. Very good.
Probably because it actually has ginger. All the ginger ale products I feel like are just, I don't think they even have real ginger in them.
Probably not. That's why I love my Moscow mules. Love that ginger. All right, so ginger containing foods. So lollipops, the Preggy Pops. Did anybody use those when they were pregnant? So they are mostly sugar. I think, so probably anything you can suck on that sugar-wise would probably do very much the same. So I gave you a picture of them, they seem to be pretty popular. Last class, before you, a lot of them had used those when they were pregnant. So ginger teas, ginger roots, cooking with them is a...
Does the sour flavor give any help on the picture? They're all
It
sour.
must, because they use a lot of the sour, like lemon, raspberry seems to be common, but I saw some other really weird stuff. Tomato flavor. I don't know, who wants some tomato flavor?
Ginger and tomatoes. Like, I love tomatoes, I hate tomatoes.
See what, when you're pregnant, if you want tomatoes. I wanted an excuse to do whatever I wanted to do when I was pregnant. Okay. All right, so those are moderate symptoms. These are over the counter, very easy to use. So secondary, so if the doxylamine and pyridoxine can't be used or they're not working, then you can use antihistamines. So antihistamines have effects on the vomiting center in the brain, so they're effective. But they bring side effects with them, as you all should all know. The C risk of reduction is 66%, so they're pretty good if you can't get effective with the first two. So meclizine, where have we seen meclizine before? If I tell you the trade name is Antivert, what do you think? So vertigo. So we talked about this in neurology. So this one's really good for that type of, so it probably works on the vestibular apparatus to decrease. You can use Benadryl, but what's the downside there? It's drowsiness. The other is, what are the anticholinergic side effects? We haven't talked about this one. Anti-slud. So constipation's in there, and that'll be a problem as they move forward. I'm sorry, Taylor, what did you say? Oh, okay. All right, so antihistamines are a second line. Be sure you know these lines. Be sure you know the progression of therapy. Third line would be using dopamine receptor antagonists. Now, probably in your Mother's Day or your grandmother's day, this was common for them to give. The same kind of drugs we would give if you went into the ER and you're throwing your guts up and you need a drug. They're very effective. Of course, most people stay away from them now or go to these others because they're effective and they have less side effects. These seem to be in small doses for short periods of time, no effect on the baby, but we're talking about antipsychotics or the phenothiazines. So like this would be like chlorpromazine would be a common one for people to use. These work on dopamine receptors, so they're going to affect the gut. So they're going to have a change in motility and keep the gut moving. And they're very good. They're very effective. So metoclopramide, Reglan. Again, we would not want to use these for long periods of time. The other is that renal function can be a problem with these drugs. However, most of the time you're going to deal with women who are healthy, and it probably won't be a problem. Most common is sedation. So like promethazine, very sedating. So warning them, working with them, if they're a working mom, then that might be a problem. So fourth line, so you heard Zofran mentioned by the two who had very severe. So this used to be a go-to. She said, I was eating it like candy. Well, that's what people did. And then reports came out of increased risk of congenital anomalies. So that's why you see it fourth line. So remember, it has a daily amount. What's the side of the big thing we're worried about with Zofran? QT prolongation. So in that group of women, it's going to be more congenital. I doubt most people even check, but you could always ask if they know. So 4 milligrams every 8 hours PRN limit. Dose limit is 16 milligrams a day. Don't use indiscriminately. That has been the last reports that have come out of the OBGYN groups. So fourth line, use other things first. Now, in those severe, what they're talking about, the first lines are not gonna work. So you're gonna have to go to those, go down the line like with these. Let's see, I think we talked about the other hyperemesis drug. Okay, questions about morning sickness? Know the progression, know the steps. I guarantee you I'll ask you something in that area. Okay, GERD. Oh, we started. This probably is a good place to stop. So let's take a break, and we'll come back at